subscribe now and press the bell icon. Never miss an update.
Welcome to Health Live at Seniors Today. We are delighted to have here with us Dr. Paresh Pai. Dr. Pai is a senior consultant vascular and endovascular surgeon at the Beach Candy, Bombay, PD Hinduja, Lilavati, Raheja and Bhatia Hospitals in Mumbai. With more than 2 decades of experience in the management of cerebrovascular disease, distal small vessel reconstruction in atherosclerotic and diabetic limbs, venous thromboembolic disease, and endoluminal treatment of aortic aneurysms. Dr. Pai is a former treasurer and secretary of the Vascular Society of India. He is a past consultant vascular surgeon at the Westmead Hospital in Sydney in Australia. Welcome to Health Live at Seniors Today, Dr. Pai. Dr. Pai, you're on mute.
Good evening, everybody. It's a pleasure to be here with you today.
Dr.
And I
Pai,
hope I will share some information with you.
yeah, we are waiting for you to make your presentation and to speak. But before I speak to you and ask you questions about the subject that we are going to speak about, just a quick word on the COVID scene as you see it, because you are, you're working out of various hospitals and your own clinic in South Mumbai. How do you view the COVID situation now and the third wave scare? Is it for real, etc.?
I think that's a very, very good question, but a difficult one to answer, because it's really, this COVID has taught us that we really are not sure about anything. What we think we know today, COVID has made us change each and everything that we thought was right. The only thing that it is consistent with is that we have to take preventive measures where social distance is extremely important, wearing a mask is extremely important, and being sensible is very, 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 very important. Everything else, you have drugs which they say that they work now, and then after some time they say they don't work. So one doesn't really know. And I've seen so many cases where after the vaccine also people have developed COVID. So just because you're vaccinated doesn't mean that you can take risks. So the whole thing is that you need to take care, and it's very difficult to predict who will get a bad attack and who will have a mild one. So as they say, prevention is better than cure.
I guess that's a message which almost everyone who comes on our shows and even otherwise says, that prevention is better than cure. And clearly that's a message that is going in. I must, at this point of time, Dr. Pai, you'll be delighted to know that Seniors Today has completed 2 years of existence. We've just had our anniversary issue out last week. That was on the 15th, and it's been 2 good years. I will, at the end of the show, show all of you the cover of this issue of the magazine and more on that. But first, Dr. Pai, over to you for your presentation on varicose veins and other vascular care for senior citizens. Over to you, Dr. Pai.
Thank you. Congratulations, Mr. Maheshwari.
Thank
That's
you.
great. 2 years is excellent. Well done. Okay, good evening, everyone. I am attached to many hospitals in Mumbai, and almost everybody asks me, how do I manage to visit all places? So basically what happens is we focus on one particular hospital or 2 hospitals, and the other hospitals we end up giving some kind of a service as and when required. So what are the topics I'm going to cover? So I'm going to share with you what are varicose veins, who develops varicose veins, and it's a self questionnaire where do I have varicose veins? So what are the symptoms? What can I do to prevent them? And what happens if I leave them untreated? And what can I do to treat them? So these are the 6 points that I'll be covering here. So what are varicose veins? So let's look at this. This is the heart, right? So the first picture shows you the heart's pumping, and it's sending oxygenated blood. That's why it's red in color, to all parts of the body, especially the legs. The legs, whenever we walk, we use what is called as a calf pump. And you can see that when you're using the movement, it's pumping the blood back. And this is deoxygenated blood, which is why it is blue in color. And you can see the third picture, which shows, third and fourth picture, which shows how the calf pump works. So when you move your feet up and down, or when you walk, this is what happens, that calf muscle pumps. There's also something called as an ankle pump, and the ankle pump contributes to 30% of the venous return to the heart. Now let's look at the veins. See, normally these veins have valves in them. If you didn't have valves, you can see what's happening, that when you're standing, when the calf pumps, the blood goes up, but with gravity, the blood tends to come down. So when you have valves which work, you can see that the blood flows up because of the calf pump. But when it tries to come back, when the pump is relaxing, the valves prevent the blood from coming back. And this is what you see here, that it does not allow the valves don't allow the blood to come back in the reverse fashion or retrograde fashion. Now, when these valves stop working, you can see what's happening. The yellow is the direction of flow along with the pump action, and blue is the one when the pump is relaxed. So you can see here that there is stagnation of blood. And just as you get a traffic jam on the road, when you have two-way traffic in a one-way street, that's exactly the same thing that happens, as a result of which the pressure in the veins builds up. The veins are usually thin-walled, and they start ballooning out, and you can see them, that this is what the ballooning out looks like, and they are called varicose veins. So why do we develop varicose veins? Why do we occur? See, this is the price we have paid for changing from a four-legged gait to a two-legged gait. And this results in increase in hydrostatic pressure in the legs due to standing. And the more you stand, the more is the pressure. So therefore, people whose occupation involves standing for long periods of time, they tend to have higher pressure in the venous system, and they end up with varicose veins. So what are the risk factors? So hereditary. So if your parents have it, you can get it. If you have it, your kids can get it. If your brothers, sisters have it, you can get it. So hereditary. Second is obesity. What happens is the fat does not give support to the veins, and the veins tend to start getting bigger because of the lack of support. Standing for long periods of time, as I've already explained. We all know that, with age, all the tissues tend to become lax. So age becomes a factor. And those patients who have varicose veins developing in their 50s and 60s, we say that it's age related. And as they get older, either they reduce the amount of standing they do or activities, or those who continue to do a lot of standing end up with more varicose veins. Pregnancy in women is also another cause where you have veins, because the weight of the baby as well as the hormonal changes during pregnancy is designed to cause all the tissues to relax. And therefore, the veins also relax, the valves relax, and as a result, you end up with varicose veins. Blood clots is a very important cause. Fortunately, it's not as common as the other causes. And when you get varicose veins as a result of blood clots, what happens is when the blood clots, it destroys the valves. And when the clots dissolve, they eat away the valves. So you have a situation called secondary varicose veins. And this is usually seen following the blood clots, and it's called post-thrombotic syndrome. So which professions are prone to develop varicose veins? Our policemen, they tend to stand for very long periods of time. So they're very prone, especially traffic policemen. Long duty hours, they're on their feet, no rest. Flight attendants are also prone because they're also on their feet for very long periods. They also can get it. Nurses are also prone because they're also feet for some time. And school teachers or salespersons who also stand for very long periods, they end up with varicose veins. So how does one know whether you have varicose veins? So we look at common symptoms. Pain. The pain is in the form of a heaviness. So this is a calf pain or heaviness that comes towards the end of the day. At night, you may get nocturnal cramps involving either the calf muscle or the thigh muscle. This is seen in almost 97% of patients who have what we call chronic venous insufficiency. Varicose veins is just a small percentage of patients who have chronic venous insufficiency. So pain is seen in 97% of cases. Swelling. Leg swelling is seen in 90% of cases with varicose veins. There are always other causes of swelling also, but pain with swelling is typically seen in 90% of cases. Varicose veins, surprisingly, is seen only in 20% of patients with chronic venous insufficiency. So here you can see that the veins are fully blown and dilated, and you can see them like grapes or like tortuous worms. Here you can see them. So they're called varicose. Varicose means tortuous. Sometimes the blood starts leaking out and you get dark pigmentation of the legs. This is seen in 11% of patients with chronic venous insufficiency. To start with, it is usually red in color. It's quite hot, and gradually with time, the red color becomes darkish or blackish, and if it continues for a very long time, you get scarring of the subcutaneous tissue or soft tissue, the fat which is under the skin, and the leg starts appearing like a champagne bottle. So it's called an inverted champagne bottle. Please forgive me, I have to share this with you because it's very important. This is a gruesome picture, but basically this is seen in 2.5% of individuals. And this is called as a venous ulcer or a varicose ulcer. It's typically in an area just above the ankle, but it can be anywhere. And usually what happens is, because of the varicose veins, you tend to get a lot of itching and you scratch, and a small wound gradually becomes a big wound like the ones I've shown. And that's because the fluid that keeps coming out, that's extremely toxic or acidic, and it eats away the surrounding skin. You can see the narrowed part here, and you can see the enlarged part here. So this is like a champagne bottle, and the ulcers are typically superficial and they have a lot of pigmentation around it, and this can be healed easily if they are treated properly. This is the other type of ulcer where you see just above the ankle. So how do we prevent varicose veins? So first thing is cut down on your weight. So control the risk factors, which include smoking as well as weight, and reduce the amount of standing that you do. This is very, very important, because if you don't control the risk factors, even when you treat the veins, there's a tendency for new veins to become bad, which are normal at the moment, because the pressure, the cause continues. So avoid standing or sitting for very long periods. Take rest, move the legs. So when you rest, what you have to do is you have to see that the foot is a little higher than the heart. So about 15 centimeters, that's 6 inches. 4 inches also good enough. Now, very, very important is how you elevate the limbs. Now, this is one way of doing it. Now, you can see here that the knee does not get any support. So a lot of doctors, a lot of people say that you elevate your legs by putting them on pillows. Now, what happens is, when you use pillows only under your foot, the knee does not get any support. The knee bends in the wrong direction. And a lot of patients who come to me also come with knee pain. The reason is the knee is bent in the wrong direction, and that's the reason why the ligaments get stretched, and that's why the knee starts hurting. This is the right way to do it, but I find that this is a little impractical for the simple reason that this involves standing or sleeping on your back. Now, we all know that nobody can continue to sleep in one position. Invariably, we turn on our sides, and this is basically designed so that we don't develop pressure at a particular point. So my preference is that you elevate the foot end of the bed from the foot end to the head end, so that it just goes up 4 inches. So what happens is, essentially you have a slope. So no matter how you sleep, your legs remain up, and it does not put a load on your back or on your knees. And therefore you don't develop complications which come as a result of this type of elevation. So you relieve the congestion of the leg. Then the next thing that you do is wear special compression stockings. So this is what we call graduated compression stockings. So what does that mean? In a graduated compression stockings, you can see here that as you go down, the pressure is more, and as you come up, the pressure is less. So this is akin to removing toothpaste from a tube. What do? You squeeze the bottom of the tube so that it comes out from the top. When you squeeze the top of the tube, what happens? Very little comes out. Most of it goes back inside. So this is the same principle, and this is what we call graduated compression. We must take great care to see that we don't use stockings like this. You can see how loose they are. You can see that they're a little tighter up and they're loose down. And this is not how stockings should be. In fact, your churidar is probably tighter than these pair of stockings. So stockings work on the basis of pressure, and therefore it's extremely important that the measurement of the stocking should be taken when there is no swelling on the leg. If you have swelling and you take measurement of the stockings, invariably you might buy either one size or two sizes bigger depending upon the quantum of swelling. And when the swelling actually reduces, these stockings tend to get loose and they don't work. So what happens is we have wasted our resources. So measurement is extremely important. The second important thing is that you should wear it first thing when you get up in the morning. So if you are very particular, you can get up, quickly have your bath, within 15 minutes, the stocking can come on. And this is particularly important in ladies because what the ladies do is they first get up, they go to the kitchen, finish off all their work, then they go for their bath and then wear the stocking. So actually when you really need it, you're not using the stockings and this creates problems. So this is the stocking I prefer. This is Swiss made. The reason I prefer this is it's premium cotton. So for our type of weather, this works out very well and it is not very hot. But yes, there has to be some synthetic component in it, that is the one which gives the pressure. So you either have knee length stockings or you have full length stockings. So we choose the size, which stockings to use based on where the problems are. So we'll discuss that a little more in the future. So exercise. Tippy toes is a very good exercise which you can use. So when you do that, you're using your calf pump and that pumps the blood and sends it up. So you can do this either in the sitting position when you're sitting and working. So move your feet up and down. Those of you who have seen, used the old sewing machines, not the electrical ones, the ones which were operated by the pedal, this is exactly the same action you do. You don't move your toes, but you move your feet at the ankle. So this exercise is important. Another important exercise that we find is deep breathing. When you take a deep breath, you create a suction in your chest, and as a result of the suction, the blood gets pulled up from the legs and comes up. So deep breathing, about 10 to 15 breaths every hour or so. If you do that, that recharges your system. Similarly, the legs, the exercise which I told you before, should be done 10 to 15 times once every hour or so. So the other things that, to just recapitulate, prevention of varicose veins involve controlling of risk factors, changing of lifestyle and habits if necessary, losing weight and controlling it, and avoid standing or sitting for very long hours. Use of compression stockings when indicated, and elevate the legs while resting. So all these are the tricks to prevent development of varicose veins, especially if you don't have it. But what about if you do have it? What happens if you have varicose veins? So you can get swelling, you can get pigmentation, you can get scarring, what is called lipodermatosclerosis. It's a big fancy name. Lipo means fat, dermat means skin, and sclerosis means scarring. So when you have scarring of the skin and the subcutaneous tissue, that is what is called lipodermatosclerosis. What I already mentioned, when you get itching, you end up with a small wound and the wound gradually becomes bigger and you end up with an ulcer. Sometimes these veins can burst, especially those which are involving the thin layer of the skin, or they form a layer of the skin. And this can happen either when you scratch yourself or when after a hot shower, when you use a fresh towel and you rub yourself a little vigorously because you're in a hurry, you can tear the skin and you can get bleeding. Or when you're walking, the corner of a table hits you in that particular spot, you can get bleeding. And thrombosis. Thrombosis means blood clots. This is the most dreaded complication. It can either involve superficial venous thrombosis or superficial veins that you see, or it can go and involve the deep veins, which is dangerous because these clots can break off and go to the lungs, what we call pulmonary embolism. And if they are large enough, they can cause drop in the pressure. And if they are very large, they can be life-threatening. And of course, pain also is an important factor that we discussed. That is 97% of times. So if you do have varicose veins, how does one treat them? So basically, there are two methods. One is called as a conservative treatment or temporary line of treatment. Why is conservative treatment called temporary? It's because as long as you're doing it, you're fine. The minute you stop, you're back where you started. This is exactly like the glasses that you wear, like prescription glasses. So as long as you use your glasses, you can see well. The minute you put your glasses down, you stop seeing well. So they never cure, but they correct the vision. So similarly, conservative treatment corrects it, but doesn't cure it. In the very early stages, if you have veins, or especially if the veins are bleeding, you can do what is called injection sclerotherapy. I will talk a little bit more about it a little later. So injection sclerotherapy, we inject a sclerosant. This is either a synthetic alcohol called palitrocanol, or it's a salt called STD, which is used to destroy the veins and damage them so that they shrivel up and shrink and die. You can also treat the veins from inside, so what we call endovenous. Endo means from inside. So when you treat the veins from inside, you get endovenous surgery, commonly also known as laser surgery or radiofrequency, which we will talk about a little bit in detail later on, or open surgery, which is a time-tested old method where you make a cut and you disconnect and remove the vein which has gone bad. And many a times it's a combination of the above methods. So this is what I was talking about, chronic venous insufficiency. So you have primary, where you don't have a set cause, or secondary to a problem. So you have either post-thrombotic or you have something called as Mayturner Syndrome. I will just touch upon this briefly so that you get an idea of what it is. When you talk of primary, or when you talk of any varicose veins, basically you talk about three systems which are involved in the leg. You have the superficial system, which is just under the skin. You have the deep system, which is deep inside the muscle. And you have the perforator system, which connects the superficial and the deep. So this is like a ladder. If you imagine one rung of the ladder going up, that's the superficial. The second rung of the ladder parallel to it is the deep system. And the steps on which you put your feet are the perforator system. So basically our system is so designed that the blood flows from the superficial to the deep system. And from the deep system, it gets pumped up and goes back to the heart. So generally, when you look at chronic venous insufficiency or varicose veins, we try to identify which system is involved. Is it only superficial system? Is it superficial and perforator system? Or it is superficial, perforator and deep system, or various permutation combinations, right? So this is what is important about chronic venous insufficiency. So when we look at the limb, we normally like to categorize the limb, whether clinically there is only presence of a valve which is not working, or in addition to a valve, there is a narrowing of the vein. So I'll just go back to this slide. When we talk about secondary, whether it's Mayturner or post-thrombotic, what happens is that there's not only incompetence or non-working valves, but there is also either compression or narrowing of the vein as a result of the clot, or Mayturners where the artery, where the vein gets pressed between the artery which crosses it and the vertebral body, which is in the lower pelvic area. So clinically, we try to identify whether there's only a vein which is valve which is not working, or the valve not working is combined with an area where there is narrowing or obstruction. So what do? We do a test called as venous Doppler. So we look at two systems: the superficial saphenofemoral system, which runs from the foot on the inside of the leg and goes right up to the groin, and you have the SP or the saphenopopliteal system, which again starts in the foot, goes behind the calf and ends behind the knee. And you have the perforator system, which are throughout the calf and as well as above knee as well as below knee, and the deep venous system, which are the deep veins. Sometimes if we suspect that there is a narrowing, when do we do that? We say if the patient has a lot of presence of pain on standing, maybe after 15-20 minutes or so, then you suspect that there is a narrowing somewhere. Or if one leg is larger than the other, or if there is constant recurrence of treated perforators or varicose veins and they keep coming back within 6 months, then definitely we have to look for another cause where there's a narrowing higher up. So it's important to correlate whether it's reflux alone or it's reflux with obstruction. So let's look at this a little more in detail. So we categorize the limb clinically. This is one limb that I was involved in treating. You can see here that this gentleman is obese. You can see that there are scarring. These are a healed ulcer. You can see what the pigmentation is like. And along with this pigmentation, this area becomes quite hard. You can see a few varicose veins here. And when I pressed and moved my finger along this line, I found that there was a dip here. So what happens is that the perforators are called perforators because they perforate and pierce the covering of the muscle called as fascia. So when they dilate, you suddenly feel a dip in the fascia corresponding to the size of the vein. And clinically, I identified that these were the three veins which were affected. So this is how we then diagnosed and treated it. Fortunately, this limb was similar to that on the other side, and therefore there was no evidence of any narrowing higher up. So again, we do a venous Doppler. This is what the Doppler looks like, where we measure the size of the veins, is the perforator vein. You can see here it's about 5 millimeters. That's half a centimeter. Normally, it should be less than 3 millimeters. If it is more than 3 millimeters, we say it's dilated. Larger the vein, more worse it is. There's also a test called venous refill time. So basically what happens is we take a sensor and we put it on the skin. And then we ask the patient to pump the leg 5 times. So this is done synchronously with the machine. The machine beeps and tells you when you have to move your feet up and down. And after the 5 movements, you sit stable. So what the pumping does is it drives the blood out of the leg. And now the machine checks, the transducer checks how long it takes for the vein to refill. Normally, it should take more than 20 seconds to refill to the original level. Now, if there is a leakage, the blood rushes back in the reverse direction and it fills faster. So more the leakage, faster it fills. So by identifying how long it takes, you can get a good idea of how bad the reflux is. So that's venous refill time. So what is the conservative treatment involved? So modification of lifestyle and risk factors, weight loss, reduced standing if possible. There are special drugs called microflavonoids. These are extracted from orange peels. So it's a natural product. It's extracted, purified, put into a tablet, and then given. So that gives strength to the veins and the valves and reduces the leakage of blood and fluid from across the vein walls. Regular use of graduated compression stocking is absolutely essential, and that's the crux of the problem. So using the correct size, using the correct pressure, and using the correct time is extremely important for these to work. Then we've already discussed exercise to improve venous return. This should be done every hour, 10-15 times. And if you have, you may consider early intervention. Probably when you do that is especially when there's a risk of complications or there's a lot of pain or risk of thrombosis. So what is the treatment here? So this is injection sclerotherapy. You use a very fine needle. It's as thin as your hair. So this is 25 or 26 gauge. Normally doctors use 23 or 24 gauge for giving intramuscular injections. People who take insulin, they use 26 gauge. So this is almost same size, 26 gauge needle. So what we do is you can see the green vein here. We have cannulated it. Now, once you get into the vein, you see the blood coming out. That's because the pressure in the venous system is high. So you inject a medicine called as a sclerosant, and then we use cold ice packs to cause the vein to go into spasm. And the vein absolutely, it's magic. It's like, take an eraser and rub the vein off. So this is typically done for early cases. This can be done as an OPD procedure. There is no hospitalization required, no rest required. We do this also for a lot of treatment with perforator veins, which we'll talk about a little later, where you get immediate result and absolutely no anesthesia, no risk, and no hospitalization. So this is what I'm talking about. So when we do this under ultrasound guidance, we call it ultrasound guided sclerotherapy. So what we do is we use this for perforators. This is typically those which cause ulcers, pigmentation, or lipodermatosclerosis. Again, the beauty of this treatment is no hospitalization, no rest required. In the past, we used to take whacking big incisions, and which used to take a long time to heal. Then with the advent of the ultrasound, we started taking small incisions. Then we started using, like you have your endoscope or laparoscope, we started using that. So from big surgery to small cut surgery to keyhole surgery to now pinhole surgery. So this is ultrasound guided sclerotherapy. This needs to be done carefully because there is a risk of blood clots developing in the deep veins if it's not done properly. Then the next thing is what everybody must have heard of is laser treatment, because laser, just as laparoscopy was the magic word 20 years ago, now laser is the magic word. Everybody wants laser. So this is the next step. Hospitalization can be either 1 day or 2 days. There are no scars involved. The problem with lasers is it uses very high temperature, almost 2000 degrees centigrade. And sometimes if you haven't given adequate fluid bath around the veins, what we call tumescent anesthesia, there is a tendency for the fat to get damaged. So it causes fat necrosis, and compared to open surgery, very much less rest is required, but sometimes it can be painful. So this is the complication here you can see. This is a patient who had veins very close to the skin. So they use the razor and it causes destruction not only of the fat but of the skin. And we had to remove all this part and then close it. The next line of treatment is what I usually prefer, and that is called radio frequency. This is basically is called as the RF closure fast system. It is the same technique like your laser, but it uses a lower temperature and therefore it is more gentle to the tissues. So it's a newer treatment. Hospitalization is just 1 day. There are no scars, no fat necrosis, minimal rest required. This is what is done. I will show you a small video clip. So we put we puncture the vein here. We put this white sheath, which is a white tube in, which is called as a catheter. You can see that there's a side arm here, which can be used to flush. And through this, there's a valve here. So we put this thing called as the RF closure fast catheter. The closure fast catheter goes from, this is below the knee. This goes and sits to 1.5 to 2 centimeters from the junction between the deep vein and the superficial vein. And this has a heating element, which is 7 centimeters long. So with this 7 centimeter long, we fire it. It takes about 20 seconds, reaches a temperature 120 degrees centigrade. And once that is done, we also monitor how much energy is required. Based on that, we know whether the vein is completely destroyed or not. So after you finish each cycle, you start pulling back by 7 centimeters. So there are markers here and you treat it in 7 centimeters. Okay. So this is what is called RF closure fast system. So this is the catheter, what the catheter looks like. This is the generator for delivering the energy. So this is what I was telling you about, 120 degrees centigrade, 20 seconds, and the wattage. Now, generally, how do we know whether we have treated is complete or not? So when this wattage comes down to 15, we know that for sure that the vein has got occluded. So around less than 18 to 15, you know that it's blocked it beautifully. And this is what we call tumescent anesthesia. What we do is we take ice cold saline, put a local anesthetic ampule in it along with soda bicarb, which is something to neutralize the pH, and we infiltrate all around the vein so that the vein goes into spasm and the vein gets separated from the adjacent cutaneous nerve called as the saphenous nerve or the sural nerve behind the calf or in the medial aspect or the inside of your thigh. It is called as the saphenous nerve, and this works beautifully because it's also it becomes almost painless. So this procedure is usually done under local anesthesia with a little bit of sedation. This is the picturization. I'll just hardly 20 seconds it takes. This is the puncture. The sheath is gone in. The black catheter is gone in. You can see the catheter going right up to the groin, but stopping 2 centimeters away. We have given tumescent anesthesia all around the vein so that the vein goes into spasm and clips the catheter. So that when we fire this, it destroys the valve and doesn't only cook the blood. Otherwise, you end up with thrombophlebitis. Thrombo means clot, phlebitis means vein, and itis means inflammation. So we don't want that. We want scarring. We don't want it to recanalize and open up later. So this is a 7 centimeters. So you keep withdrawing 7 centimeters and treat the whole vein one step at a time. This is not a blind procedure. It is monitored under ultrasound. So actually we are seeing what is happening. And step by step, the whole thing is done. You can see now the ultrasound machine. So you're withdrawing it 7 centimeters at a time. This is under ultrasound guidance. So you can see it being withdrawn. And that is what we do for this. So what is the difference between endovenous radio frequency? This is what is also called radio frequency, and endovenous laser therapy. So this is a sheep liver where they have put both the catheters. And you can see here that with the closure fast catheter, 120 degrees centigrade, the amount of tissue damaged around is very small. But see the amount of damage that takes place with the laser catheter because of very high degree, 2000 degrees centigrade. Now they also have something called as a radial catheter, which does not generate energy just at the tip, but along the length, similar to this. And that is more gentle, but the temperature is still the same. So this can create problems. There is a study called recovery study, which suggests that patients who ended up with RF thermal ablation were significantly superior to laser as measured by comprehensive array of post-procedural recovery and quality of life parameters and randomized prospective comparison between these two thermal ablation modalities for closure of the long saphenous vein or the great saphenous vein. So this is a study which I wanted to share with you. Now there is a newer treatment now. It's called glue. So this is what you do is you inject the glue and then you give pressure. So the whole thing seals off. So this is the latest therapy, again done as an OPD procedure or less than what we call daycare. There are no scars involved, there is no fat necrosis, there is no tumescent anesthesia required, and very minimal rest required. So it's generally called as an office procedure, and some people say that, during your lunch hour, you can come get it done and go back to work. And last and not the least is the open surgery, where we make a cut in the groin. We disconnect the superficial vein from the deep vein, and then we use this device called as a stripper. So it's tied up and it's pulled down. The problem with this device is sometimes there can be hematomas, which can be quite significant, or there can also be injury to the nerve if it is close by. So it's a later stage. It's used when the veins are extremely tortuous. 3 days hospitalization, small scars. Usually there's a rest of 7 to 10, 15 days, whereas in the others, you hardly need any rest. Another method to take rid of the big veins which are there, we call multiple avulsions, where we make a small stab incision. Through that, we put this hook. The hook goes and pulls the vein out. And then using these forceps, what are called artery forceps, we gradually tease the vein out and pull it out. So this is an open technique. We use vein hooks. There are also devices called tumescent VNMS, which is tumescent anesthesia machine with a rotor and suction, but it can cause quite a bit of injury. Now, what happens if there is reflux and obstruction? This is Mayturner Syndrome, which I talked about, venoplasty and stenting. You can see here, this is what the leg looks like. It's swollen. You can see the scarring and the redness and the pigmentation. And this is the area where the perforator is incompetent. And this leg was a little bigger. We do what is called MR Vinogram, when you can see here that in the abdomen, this is the main vein called as the inferior vena cava, and the main artery is the aorta. Now, on the left side, the right artery, which goes towards the right leg, crosses the left vein. And this is where the vein gets sandwiched between the artery and the vertebral body. And that's where you can see that there is a deficiency here along this, suggesting that there is pressure. You can see that better on the transverse section, where this is the vertebral body, this is the vein, and this is the artery sitting here, which is compressing the vein. So generally, when we do that, when we see that, what we do is, we do either what is called IVUS or intravascular ultrasound, or a simpler and cheaper method is using the balloon. So when we inflate the balloon, you can see here that there is a waist. Can you see how the waist is improving? And once the balloon is fully dilated, we keep it open by using what is called as a stent. These stents are similar to the stents which are used in the heart, but in the heart, you're using 2 millimeter, 3 millimeter, 4 millimeter stents. These are 16 millimeter stents. So they're large stents. And now you have special stents which are meant for use for this purpose. And they have what is called as an open cell design. So they allow blood to flow through the struts of the stent. Now, the other type of thing is post-thrombotic syndrome, where you have to do venoplasty and stenting, or sometimes you have to do venous bypass. This is one gentleman who works as a medical representative for a reputed multinational company. You can see that he has swollen legs. You can see the amount of scarring of the ulcers. See the black discoloration. And again, here you can see that it's narrowed out here and it's distended here. Now, this gentleman had a duplicated inferior vena cava. You can see this is one and this is the other, but it is all thinned out. You can see it thinned out. This is a normal vein. This patient ended up with using almost 5 stents. And because it was the government, it was his company paying for it, he could afford it. Now, these are varicose veins. After 26/11, I had held a varicose vein camp for traffic policemen in their traffic police headquarters at Worli. This was after the 26/11 terrorist attack. We did this under the banner of the Vascular Society of India. We examined 66 policemen, 132 limbs. They had pain in 38 limbs of 24 policemen. Swelling was seen in 45 limbs of 31 policemen. Frank varicose was seen in 35 limbs of 21 men. And the treatment required involved stockings for treatment in 58 limbs, simple endovenous surgery in 19 of these limbs, complex surgery required in again 19 of the limbs. And I'm sorry to say, but unfortunately, our government policies are such that's the only organization where you take a fit, healthy person and make him unfit. Because if he has varicose veins, he is not given employment in the police force. So health checkup pre-employment and failed if he has varicose veins. And what happens is You make them stand for long periods, don't give them stockings. And when they do develop varicose veins, you don't pay for the treatment after you have caused the varicose veins because of your job. So that's a sad thing. We try to change it, but haven't really made much difference. So friends, ladies and gentlemen, this is our motto, limbs for life. This is this which deals with what a vascular surgeon does. We deal with arteries, we deal with veins. In arteries, we do surgery to prevent stroke. In arteries, especially the leg arteries, which get narrowed, we have difficulty walking. So there what we call claudication. So we use various methods, medication, as well as angioplasty, as well as bypasses. If patients have leg ulcers, we use different methods to get the ulcers to heal. Particularly when people have been running from pillar to post, seeing many doctors, and still the wounds don't heal. Diabetic patients who end up with ulcers or wounds, they are also called diabetic feet, and we use them. And maybe some other time, when time permits, we can plan it, but I can give you a session on diabetic foot. And for the venous side, you have arteriovenous malformation, where there's an abnormal communication between arteries and veins. So venous, we have already talked about varicose veins. Sometimes there's deep vein thrombosis. So that's another session that we can talk on. Leg pain. Leg pain is a very important point, and I see a lot of patients who come with leg pain. And really, it's like playing Sherlock Holmes. When there are so many causes of leg pains, and if you hit and find out the exact cause of the pain, then the treatment is easy. And with very simple techniques, you can relieve the patient of the pain so that they don't have to take painkillers. And swollen legs that we talked about, varicose veins or post-thrombotic or deep vein thrombosis. A lot of patients ask me, or people ask me, what is this? So these are lymphatics. Lymphatics are those which carry the fluid from the body, and they are extremely important for carrying away infection. So patients with filariasis, they end up with huge legs called elephantiasis or elephant legs. And we also offer treatment for these patients. We do our best to see that we avoid surgery for these patients, and surgery is reserved only for absolutely, cases which are very advanced. Thank you, and it was indeed a pleasure being with you. I am open to questions. Back to you, Mr. Maheshwari. Thank you.
Thank you, Dr. Pai. I think you've answered most of the questions that people could have asked. But there are a few questions that have still come in, and I'm going to only raise some of the questions that have been that you have perhaps not answered, and some specific cases. Doctor, there's a question from KD Dadanchi, who says, Doctor, would compression stockings worn on the legs help arrest further progression for the veins, and they'll get back to normal? My husband is 76 years old and is not keen on any procedure being done, as his veins are not that pronounced and are not giving him any trouble. He has a slim build.
Yeah, so basically, as I mentioned, the stocking is not going to make it go back to normal, but it will prevent it getting worse. And not only that, it will compensate for the veins which have become bad. So it gives pressure and support. So in the very early stages, when you don't have anything, we use support stockings. And when you have these veins, we use class 2, which gives you a pressure of about 30 millimeters of mercury. So it's 20 to 30 millimeters of mercury at the ankle. So it's called class 2 stocking. So if he has veins, you should use class 2 compression stockings. And definitely these should be used for people when they are traveling, when they're sitting for long periods of time, when they're flying, or when they're traveling by bus. You must use these to prevent deep vein thrombosis.
Right. Thank you. We have a question from Meher Balsara, who says, what do you recommend for someone who has incompetent perforators behind both knees while flying?
Yeah, so that's exactly what I said. That's why I mentioned the word flying, to take care of that particular question. So use stockings, do the exercises that I've talked about, and that will keep you out of trouble. If somebody has a history of developing blood clots and the veins are really bad, sometimes we use blood thinners to prevent clotting. So it all depends on what the causes are.
Right. Thank you. We have a question from...
What is foam therapy?
Foam therapy, yes.
So what we do is, when we are doing the injection treatment or sclerotherapy, what happens is the quantum of the material that is used can be quite large. So we minimize the quantum of the sclerosant use by mixing it with air, and using a syringe, we create what is called as a foam. So you use less quantity of the material, increase the volume of it so that when you inject it, there are less side effects, and that is foam sclerotherapy. Usually it is done as an injection. That's why it's called injection foam sclerotherapy. And because you do this under ultrasound guidance, it's called USG guided, ultrasound guided injection foam sclerotherapy.
Right. Thank you. We have a question from Sunita Michandani. How many sessions are typically required in the new age treatment?
It depends on which systems are involved, how many systems are involved, and how many veins you have. Because when you are using, we try to minimize the number of sessions that are required. But the important thing is that if you have too many veins, then what happens is there's a certain amount of dose you cannot exceed when you are using the sclerosant. So therefore, you may need to stage the procedure. And generally, the patient tells us, when we inject the sclerosant and you've reached a certain quantum, patient tells you, starts coughing, gets a dry cough, or tells you there's a tightness in the chest. That's my signal to say that I have to stop for today, and then maybe take it up after 2 days more. So it's very difficult to give a broad answer, say how many sessions, but we try to minimize it and do it in a thing which is most convenient and very safe.
We have a question from an anonymous attendee who says, I've always had varicose veins, but is that the reason for my inability to stand for more than a very short time, or does it have to do the back? Also, if I buy stockings, how much time should they be worn at a time? Thank you.
See, cause of pain on standing can be multifold. Like you rightly pointed out, it could be related to back. It could also be related if you have weak bones, what we call osteopenia or osteoporosis. More common in women after their in the menopausal age group, and generally seen in people who don't go out too much, who avoid drinking milk or milk products because either they don't like it or it doesn't agree with them, or what happens is they don't want to put on weight. So therefore, what happens is your calcium levels go down, your vitamin D levels are low because you're not out in the sun, and as a result of that, the calcium leaches out of your bones. Bones become soft and the bones start hurting. So whenever you stand for a long period or even sit for a long period, what happens is the area of the bone which gets the pressure starts hurting. So typically if you stand, you will find you get pain in either in the ankle, in the feet or the ankle, or on the front of the legs or on the side of the legs, especially if you're sitting and resting against a particular object, a hard object with pressures on the bone. You can get that. If you're sitting for a long period, suppose you go for a movie, you may find that your buttocks start hurting, your back starts hurting. Typically, a lot of these patients who have very severe osteoporosis, they are absolutely like a fish out of water. They can't sleep in one position for a long time. So they keep tossing and turning and moving because they keep getting this pain. Also, these patients also end up with a lot of cramps. So therefore, when I assess patients with leg pains, I have to consider all the factors and then pinpoint what the cause. Many times you may have more than one cause. So therefore, you've got to prioritize and then tell the patients and educate them. And once you get rid of the main factor, then you can deal with the veins at a later stage.
Doctor, there's a question from Sunita Michandani who had asked a question earlier. I have a problem since the last 50 years. Does this mean that I may not be able to be treated?
No, not at all. It's better late than never. But it all depends. See, generally, there are 5 reasons why we go ahead with this treatment. One is if you cosmetic. So that's generally seen in younger individuals. Less common in women, in Indian women, because generally they either wear saris or they wear dresses where the feet are not seen or legs are not seen. Second is pain. Third is bleeding. Fourth, again, very rare in the senior age group, but people who go for jobs and they get failed from the medical, we treat them. So a lot of people who go for the army, police, or for many other jobs which involve standing, we do treat them. And if you find that they are increasing in size gradually and steadily, then that's one of the indications where you should go ahead and get it treated.
Thank you. Dr. K.D. Dadanchi asks, where can I buy these class 2 compression stockings?
There is a company called Labmedica which imports it, and that is the one which I have recommended. The number is 2808-5040. You need to call between 10 a.m. and 6 or 4 p.m.
Right. We have a question from Ajit Kumar Bhaskar Menon, who asks, once one is on a blood thinner for DVT, after the improvement, when can one stop the medicine? Any induction for stopping medicine?
Yes. Generally, when somebody gets DVT, we try to identify what the cause is. So you have two types of systems. You have a provoked DVT and an unprovoked DVT. In an unprovoked DVT, what is seen is that the risk of developing a clot again is 10% at 1 year and 30% up to 30% at 5 years. So initially we used to say if it's unprovoked, you don't need to take for a long time. But there have been studies which have come up in the last 5 years, which suggest that you need to take it at least for 5 years if it's an unprovoked DVT. If it's a provoked deep vein thrombosis, you have to look at what is the cause. Is it a transient risk factor? Like for example, suppose you've had injury and you've been immobile, or you've had surgery and you're immobile, or if you have done long distance travel. So in those cases, you can give it only for 3 to 6 months. But if it's a transient risk factor, or it's a persistent risk factor, for example, malignancy, or somebody who has to take hormonal pills for treating medical conditions, or if there is something wrong with the blood, then you have to take this medication lifelong. So therefore, the cause and whether it's provoked or unprovoked and how bad it is important. The second thing we look at to decide whether we need to give for a long term or not is what is the risk of bleeding. If the risk of bleeding is high and the risk of clotting is low, we don't give the blood thinners for a very long time. And if it is vice versa, so basically you have to customize it based on the risk factor of repeat DVT as against the risk of bleeding.
Right. Doctor, we have a couple of questions which are drug related. Does consuming magnesium 400 mg capsule help as a remedy in this case? And there's another question which is, does Daflon help in relieving varicose veins in the long term?
Yes. So when I talked about microflavonoids, I was referring to Daflon without actually taking the name of a particular pharmaceutical product. So Daflon is a natural, purified, micronized, and this is exactly the system. That is the one which I use. It comes in two strength, 500 milligrams and 1000 milligrams. 1000 milligram can be taken once a day. 500 milligram is to be taken twice a day. What I find is that the elderly, they may not tolerate 1000 milligram taken once a day, and therefore it might be better to take 500 milligram twice a day. There are very few individuals who don't tolerate it. It's an extremely safe medication. It's so safe that you can give it to pregnant women. Now, what was the other question
the magnesium.
The first part.
Magnesium.
Magnesium. Right. No, magnesium it's a general trace element which is used. It doesn't have any specific action against varicose veins in particular. Otherwise, we would have been using it for all our patients. But no, I mean, there's no harm. You can take it as a general medication.
There's a question about, are there any natural foods that one must take to ensure that one doesn't get varicose veins?
No, nothing like that. But they do talk about consuming horse chestnut oil, which is used for basically similar mechanism as a microflavonoid. So these are things that can be used naturally.
There's one last question. My feet have tiny blue veins. Could you speak of that? An anonymous attendee.
Yeah, so these are go by three names. Either they are called as spider veins, or they are called venous telangiectasia, or they are also called as superficial varicose veins. So depending upon the size, you treat them differently. Now, when you treat them with sclerotherapy, since they form a layer of the skin, there's always a risk involved that when you inject these veins, that you're destroying a layer of the skin. So what the body does is it removes the damaged part and then replaces it with healthy skin. This can take from few days to a few weeks to maybe up to 3 months. So that can be a little laborious process. And when we are treating these type of veins, we always warn the patients that this is a possibility. And it's not dependent on how we do the procedure. It depends on how much of the vein is involved, how much part of the skin is involved by the vein. So if there's a significant involvement, yes, there is a risk that can happen. And that is what we do. And generally, these veins need to be treated primarily because the risk of bleeding is very high in these veins.
Right. Thank you, doctor. There are a few questions that have come in when people are asking about whether they can consult you. Where's your consulting practice? Do you practice in, do you visit any hospital in Pune? We do know that you have a consulting, you have your clinic in South Bombay. Could you give us the details? And of course, we'll put it up on our.
Sure, I'll do that. My clinic is in South Bombay at Gamdevi. Pre-COVID, I used to have OPDs in three hospitals, sorry. One was Lilavati, second was Hinduja, and third is Global. At the moment, during COVID times, I'm only visiting Hinduja Hospital for the OPD, which is on Friday in the morning at 8 o'clock. And in the clinic, I'm there every day, Monday to Friday, between 10 a.m. to 2 p.m. The clinic numbers are 2380 4400 or 2380 4499, or there is another number which is a cell number where you can WhatsApp 98694 26541. So 98694 26541. So you can reach out and we can have a look. And generally, the advantage of clinic is we've got everything on the computerized and database. So if generally you call up at some time or you have some questions or something, it becomes easy for me to check the file and give you an answer. Whereas in the hospitals, the files get put in the hospital and I don't have access to them online. So therefore, it sometimes becomes difficult to answer. And the other advantage in the clinic is we have an ultrasound machine in the clinic where at no charge, I use that to scan and look out and get a better idea of what's happening inside. And then we get a formal ultrasound done for safety reasons and to get an unbiased report from somebody who is very good at doing the work. Venous refill time, which I talked about, we are the only place in Bombay who do this test. It's not done anywhere else. So that is what we do it. And I'm sorry, I don't visit Pune. The number of places here is enough to keep me tied up that I have difficulty managing.
Doctor, do you do teleconsults at all?
Yes, in this COVID time, we are doing teleconsults, and while they do help, but they are absolutely, actually seeing, examining and talking gives more information and gives us a better guide to correct treatment and customizing the treatment for patients.
Right.
But yes, I do teleconsult. Those numbers which I gave you, you can always contact them and we can schedule a consultation whenever you like.
Thank you, doctor, very much for all your time. We've spent almost an hour here. For those of you, there were a couple of questions. So the video recording of Dr. Pai's presentation, as well as the entire session and all the responses that he gave, they will be edited and put on the Seniors Today website on Monday morning. There will be the takeaways also. The text of the session also will be put up, and you can access it on Monday morning. Thank you, Dr. Pai, once again. And for those of you who are here, I must, I'm sorry, doctor, I must take 2 minutes to tell all of you, since not everybody was here at the very beginning. This month, Seniors Today has completed its 2nd anniversary. And I must request our producer to quickly share the screen and show the cover of this magazine. We've had, so this is the cover of the magazine. It's if I might call it, an unputdownable issue. We've had a fantastic 12-page interview with Mr. Harsh Mariwala, who's chairman of Marico. And the interview was fantastic. And you must, so I've just asked a producer to go through the contents page. We have an excellent column by Mr. Harsh Goenka, who is chairman of RPG Enterprises, and he's spoken about rediscovering happiness in these COVID times. There's an interesting letter from our publisher, Mr. Vikram Sethi, about a letter from a father. There's an article by Vandana Kanoria on being a grandparent. There's Mr. Nagesh Alai, who was a former advertising CEO. He's talking about strangers that you meet on a walk. There's a photo feature by Urvi Piramal, and there's an article on deep sleep. 21 healthy alternatives to everyday life. I asked Bemin, the well-known sports journalist, has written on the Olympics, which start on the 23rd. Those of you, since we have senior citizens here, we have an article by Prabhakar Munkor, which talks about the aunties bars that used to exist in Mumbai pre-prohibition, that is pre-1972. And Narendra Kusnur writes about duets since it's a second anniversary, and Deepa Gehlot has her reviews and recommendations. So I'll show you the cover once again. It is our second anniversary issue. It is available free of cost. It's an e-magazine, and you can go to seniorstoday.in and access the magazine. We've had fun putting it together. It's a huge milestone for us to complete our second anniversary. You know that we've been doing the health webinars every Saturday at 5 p.m. and we'll be back once again next Saturday for another session of Health Live at Seniors Today. At this point, I must thank you once again, Dr. Pai, for a very enriching session. And I'm sure it has answered most questions of everyone around. And those of you who wish to consult with Dr. Pai, you have the phone numbers, and we will have them once again on our website on Monday morning. Thank you once again, Dr. Pai, for this session.
Thank you. Thank you. Bye-bye. Have a nice weekend.
Thank you. You too. Bye.